In UR 2106 group assignment, we chose to do the respiratory system, and our condition is chronic obstructive pulmonary disease, COPD, and we'll be discussing both emphysema and chronic bronchitis. Steph will be discussing the pathophysiology of COPD, Karat will be discussing the pharmacological interventions, Andrea and myself will be discussing the nursing management, and I'll also be talking about national safety and quality health service standards. Our case study. We'll be presenting our case study using the clinical handover tool ISBAR. Identify. We're looking at her wristband. Her name is Jane Smith, date of birth 7th of March 1967. Her URI number is 268841. Gender female. Her height is 158 centimeters, weight is 47 kilograms, and BMI is 18, and she's underweight. Situation and observations. Presenting complaint on hospital admission. She has dyspnea, difficulty breathing, shortness of breath, making it difficult to eat or speak, tightness of the chest and pain, unable to walk more than 20 meters. She has cold fingers and toes and is also coughing up a yellow-green sputum. Background lifestyle. She's a heavy smoker, smokes 20 cigarettes per day since age 20, so 30 years of smoking. She doesn't drink any alcohol, she lives alone and works full-time at a post office. Doesn't exercise, has no family history of COPD and nil known allergies. Background, past medical history. So she has a past history of COPD and was admitted 2 months ago with a chest infection. She also has pulmonary hypertension and asthma. Her assessment and clinical manifestations is that she has low oxygen saturation of 86%, a heart rate of 110 beats per minute, blood pressure of 142 and 85, respiratory rate of 28 breaths per minute, and also her extremities are observed to be blue and purple in colour. The recommendations and requests will be discussed later during the nursing interventions in this presentation. National Safety and Quality Health Service Standard 6, Clinical Handover. This standard integrates a communication tool to collaborate patient-specific information when liaising with other healthcare workers, patients and family. Clinical handover supports safe patient care, generally following a systematic approach addressing all information using ISBAR.
I'll be talking about the pathophysiology of chronic obstructive pulmonary disease. So chronic obstructive pulmonary disease, COPD, is an inflammatory condition affecting the central and peripheral airways, lungs, alveoli, and pulmonary blood vessels that is not fully reversible. It includes chronic bronchitis and emphysema. Chronic bronchitis involves coughing and sputum production for a period of at least 3 months in 2 consecutive years. Emphysema involves a decrease in alveolar surface area and destruction of alveoli, impairing gas exchange. The main symptom of emphysema is shortness of breath. Disease process. When irritants are inhaled, inflammatory cells including cytokines, neutrophils, and macrophages release inflammatory mediators. These create a sustained inflammatory response, leading to tissue damage, such as through the release of elastase that damages elastin, crucial in lung compliance. The airways become remodeled from fibrosis and accumulation of scar tissue, causing them to narrow and reducing the capacity of the lungs. Irritants include tobacco smoke and air pollutants such as vehicular and industrial irritants. Risk factors for COPD include workplace exposure to dust and fumes, tobacco use during pregnancy, a history of asthma, as evident with the patient, and childhood respiratory infections. Manifestations and pathophysiology. So the manifestations of COPD include excessive mucus production due to an enlargement of mucus-secreting glands, proliferation of goblet cells, a loss of lung elasticity, increasing viscosity, and disruption to the mucociliary escalator, preventing clearance and removal of mucus. This manifests in the patient through their coughing and production of yellow/green sputum. Tobacco use also leads to the invasion of inflammatory cells into the submucosa and glandular tissue of the lungs, increasing mucus production. This will be occurring as the patient is a smoker. The result is excessive coughing and sputum production and airflow limitation. Shortness of breath caused by inadequate ventilation due to alveolar destruction, as well as tachypnea, are further manifestations of COPD. This is evident in Mrs. Smith's presentation with shortness of breath and a respiratory rate of 28 breaths per minute, above the expected number of 10 to 20 breaths per minute. Accessory muscle use, including the use of abdominal muscles and intercostal muscles, also feature in COPD due to the necessity for forced expiration. This is due to a loss in lung elasticity, reducing the ability of the lungs to passively recoil by themselves. COPD is in contrast to normal lung function. Normally, the lungs are elastic, and there is no inflammation of the bronchi and no fibrosis evident, therefore there is no airflow limitation. Mucus production occurs at an acceptable level to trap foreign particles, and there are intact clearance mechanisms. The alveoli are also at an adequate size to allow for suitable gas exchange and are plentiful in number. Complications. Some of the complications of COPD include a diversion of blood away from the alveoli due to poor ventilation via pulmonary artery constriction. This leads to hypoxemia, low oxygen in the blood and impaired oxygen distribution, due to poor gas exchange leading to cell and tissue death. This explains Mrs. Smith's presentation of cold fingers and toes and blue/purple extremities. A further complication of this is pulmonary hypertension and right-sided heart failure. This is due to a lack of blood flow to the right ventricle of the heart due to the constriction of the pulmonary arteries. Cardiac failure can ensue. Another complication of COPD is carbon dioxide retention. Whilst normally chemical receptors in the body will detect high levels of CO2 and subsequently stimulate an increase in respiratory rate to aid its removal, hypercapnia or high CO2 levels in COPD leads to a reduced sensitivity to CO2. This reduces the stimulus to breathe, posing a problem in the administration of oxygen therapy. Another complication is systemic inflammation due to sustained elevated levels of inflammatory mediators in the body. These substances can cause the liver, bone marrow, and adipose tissue to produce and release excess white blood cells. This leads to chronic systemic inflammation, a risk factor for heart disease, osteoporosis, lung cancer, and diabetes. Further complications include metabolic diseases such as obesity, stroke, skeletal muscle weakness, and anemia.
Oxygen therapy. Mrs. Smith requires oxygen therapy due to her low oxygen saturation. However, because she is a COPD patient, we would expect her oxygen saturation to remain low. It is also used for treatment for hypoxia. Contraindications include: it is important for the nurses to take into consideration that Mrs. Smith should not be given high doses of oxygen due to her previously existing COPD condition. Another contraindication includes oxygen therapy is administered through a short period of time in order to eschew toxicity. Side effects include O2 toxicity and apnea. Associated safety and monitoring required include the dose delivered should be titrated based on O2 saturation and O2 blood level. Arterial blood gases and oximetry reading should be monitored. Salbutamol. Salbutamol is a short-acting bronchodilator which aims to dilate the airway so the patient can breathe properly. Salbutamol is required because Mrs. Smith is presenting with symptoms such as chest tightening and dyspnea, which indicates that she is having trouble breathing. A short-acting bronchodilator would be effective to relieve her presenting symptoms. The mode of action is to relax bronchial smooth muscle by stimulating beta-2 adrenoceptors. The route used for a salbutamol is usually a nebulizer. Indications include symptom relief of asthma and COPD, prevention of exercise-induced bronchoconstriction. Contraindications for salbutamol include that it is a risk factor for angle closure glaucoma. Side effects include inhalation of beta-2 agonistics is preferred to minimize beta-1 adrenoceptor effects that follow significant drug concentrations in the blood from parenteral administration, for example, tachycardia and arrhythmia. Other side effects include tremor, palpitations, and headaches. Precautions of salbutamol include any patient with hypothyroidism increases the risk of cardiovascular adverse effects, and patients with diabetes risk of hypoglycemia with high doses. Associated safety and monitoring required include check of signs of breathing better, including no signs of previous distress such as tripod breathing or nasal flaring. Beclomethasone. Beclomethasone is a common type of corticosteroid used to prevent inflammation. The route used for administering beclomethasone is usually an inhaler. Indications include maintenance treatment of asthma and to reduce airway inflammation and bronchial hyperactivity. Contraindications include skin thinning and bruising, and there's increased risk of this with higher doses, particularly in older patients. Other contraindications include hypersensitivity and status asthmaticus. Side effects include dysphonia, oral thrush, bruising, and facial skin irritation followed by nebulization. Precautions include for COPD patients, inhaled corticosteroids may increase the risk of pneumonia. For patients who smoke, asthma patients who smoke may respond less well to inhaled corticosteroids than non-smokers and may require higher doses. Associated safety and monitoring required include to assess adrenal suppression, assess blood studies including neutrophils and white blood cells, checking nasal passages for changes in mucus, assess respiratory rate, and counseling. Remind the patient to regularly clean the mouthpiece of the inhaler to prevent nozzle blocking. The fourth and final pharmacological intervention includes vaccines and antibiotics. The uses of antibiotics and vaccines are suggested in medical surgical nursing textbook. In particular, the pneumococcal vaccination should be administered for COPD patients. For antibiotics, it is important to await on sputum culture results. In case of suspicion, a broad spectrum antibiotic is prescribed. For vaccinations, immunization against pneumococcal pneumonia and yearly influenza vaccine are recommended to reduce the risk of respiratory infections.
Pharmacological management should always incorporate the use of NSQHS Standards 3 and 4, National Safety and Quality Health Service Standard 4, Medication Safety. This standard addresses the importance of safe administration of medication when using the 7 drug rights: right patient, right drug, right dose, right route, right time, right reason, and right documentation. This protocol is enforced to reduce the number of medication errors and to improve the use and quality of dispensing medicines within legislative requirements, policies, and guidelines. This standard is used in conjunction with Standard 5, patient identification and procedure matching to adhere to the right patient component, ensuring medication is administered to the correct patient as stated by the medication chart. It is important to educate the patient about the drugs and reference to the medications handbook to understand their drugs' pharmacodynamics. National Safety and Quality Health Service Standard 3, Preventing and Controlling Healthcare-Associated Infections. This standard encourages the use of aseptic practice and hand hygiene within healthcare settings to assist in decreasing the spread of infection. To manage and prevent infections, the 5 moments of hand hygiene should be used.
So I'll be talking about nursing management. There are a number of nursing management strategies to treat and prevent COPD. Some we will discuss today are the cessation of smoking, pulmonary rehabilitation, and patient education. So cessation of smoking. Cessation of smoking is a medical management and has shown to be the most cost-effective intervention to reduce the risk of developing COPD and to its progression. The nurse should encourage and give continuous support to Ms. Smith in the process of the cessation of smoking. Cessation rates increases with the help of support and intervention, which includes practical counseling and social support arranged outside of treatment. Since Mrs. Smith is a long-term smoker, nicotine replacement can be recommended. Nicotine is a first-line pharmacotherapy that reliably increases long-term smoking abstinence rates, and it comes in different forms, for example, gums, inhaler, nasal spray, transdermal patch, and sublingual tablet. Pulmonary rehabilitation. Rehabilitation should be offered to Mrs. Smith as she is of a moderate to severe COPD patient. She also has a long-term respiratory disorder characterized with dyspnea. Pulmonary rehabilitation incorporates a number of nursing interventions to treat COPD with its primary goal to reduce Mrs. Smith's symptoms, decrease the number of hospitalization as she was admitted 2 months ago, increase her physical and emotional participation in everyday activities, all in all to improve her quality of life. The nurse should advise Mrs. Smith to undergo this rehabilitation for at least 6 weeks, as this is the minimum effective length of pulmonary rehabilitation is 6 weeks. The longer the program, the more effective the results. It can also be continued when Mrs. Smith is discharged, as it can be conducted in inpatient outpatient, or home settings. Breathing exercises. Breathing pattern of people with COPD is shallow, rapid, and inefficient. The more severe the disease, the more inefficient the breathing pattern. Breathing exercises can improve Mrs. Smith to a diaphragmatic breathing, which reduces respiratory rate, increases alveolar ventilation, and sometimes help expel as much air as possible during expiration. Pursed lip breathing aids slow respiration, prevents collapse of small airways, and helps the patient control the rate and depth of respiration. It also promotes relaxation, enabling the patient to gain control of dyspnea and reduce panic feelings. Activity pacing. People with COPD like Mrs. Smith might have decreased exercise tolerance in the morning because bronchial secretions have collected in the lungs during the night. The nurse can help Mrs. Smith reduce these limitations by planning self-care activities and determining the best times for bathing, dressing, and other daily activities. Physical conditioning. People with COPD benefit from exercise training programs. These trainings result in an increase of exercise tolerance and decreased dyspnea and fatigue. With this, Mrs. Smith is able to increase her walking distance. Physical conditioning includes breathing exercises and general exercises intended to conserve energy and increase pulmonary ventilation. Graded exercises and physical conditioning programs using treadmills, stationary bicycles, and measured level walks can improve symptoms and increase work capacity and exercise tolerance. Nurses and physiotherapists should work together to keep track and monitor the progress of Mrs. Smith by using a pulse oximetry, dyspnea scales, heart rate surveillance, and 6-minute walk tests. Mrs. Smith should also be advised to have continued participation in at-home exercise or maintenance program.
Nutritional therapy. Malnutrition can exacerbate symptoms of COPD and can cause Miss Smith to be more susceptible to infection due to her reduced immunity and also increasing the chance of deterioration in her health. Treatment plans and regular screening tools such as MUST, the Malnutrition Universal Screening Tool, can help prevent significant weight loss and promote weight gain to increase the chance of a better outcome. Symptoms of COPD such as difficulty swallowing, breathlessness, dry mouth, reduced appetite, early satiety, anxiety, and depression can affect the nutritional intake by Mrs. Smith. If Mrs. Smith continues to decrease in weight, the collaboration with dietitians and counselling can help improve her health and help prevent the exacerbation of COPD symptoms. Dietitians would educate and advise the regular consumption of fluids to assist in lubricating the throat when coughing up sputum, encourage Miss Smith's diet to incorporate a balance of energy-rich and high-calorie foods to sustain her energy, improve her immunity and functioning of her organs, and also encourage small, soft food meals to make it easier to consume when short of breath. Patient education. Education is an essential nursing element in the prevention of COPD deterioration. By educating patients like Ms. Smith about the physiology and risk factors of COPD, they can better understand how it works, what its causes are, and how to prevent precipitating factors that can worsen their condition. Stressing the importance of the impact smoking has on the lungs can hopefully help with people quitting smoking. Cessation of smoking is a vital part of pulmonary rehabilitation, and extra support groups and associations should help support them during their withdrawals. Encouraging Ms. Smith and other COPD patients to get physically active and change their lifestyle can significantly reduce symptoms of COPD, improve their physical health, and ultimately change their outlook on life. In conjunction with breathing techniques, patients can enhance their oxygen intake and control their breathing, making it more comfortable for them. Nutritional intake is crucial to help immunity and provide functional energy for the body. As many people like Ms. Smith can be underweight due to symptoms of COPD, it is important to ensure they get an adequate intake of nutrients and energy to help to prevent worsening of their condition and help them live a healthier life. In conclusion, education on how to manage COPD and support from multiple health alliances can help provide COPD patients with the foundations to cope with their symptoms and live their lives to the best of their abilities.